Introductory settings on the ventilator. Some of this is ventilator mode dependent, but let's just start with, let's just say you have a patient, stick figure person number 1, who unfortunately has a really bad pneumonia, so they end up on a ventilator. What that means is they have an endotracheal tube, right? It goes into their mouth, down into their trachea, and hopefully sits right in the trachea above the carina. And you have their lungs here. This is a beautiful picture. This is anatomically accurate. Y'all are welcome. And that endotracheal tube is hooked up to a ventilator by tubing, and that ventilator pumps air in and out of that patient's lungs. And the ventilator has a big screen, and this screen is going to be dependent on the brand of ventilator, but a lot of them share similar introductory settings. And for this video, the settings are going to be for volume control or pressure control. We're not going to go into more advanced modes of mechanical ventilation such as SIMV or APRV or pressure support or what have you. This is going to be for volume control and pressure control, specifically volume control, assist pressure control. So with these types of settings, the ventilator, many of them have 4 options on the bottom of the ventilator. And these 4 options are going to be the basis of this video. And those options are going to be the PEEP, the FiO2, the respiratory rate, and then either the tidal volume or the pressure control above the PEEP. And that's what we're going to talk about today, all 4 of these. So starting with the PEEP. The PEEP stands for positive end-expiratory, one too many E's, good for us. Positive end-expiratory pressure. So positive end-expiratory pressure. Lots of words. And what that is that is a constant pressure that the ventilator is always giving the patient, right? It doesn't matter if it's inspiration or expiration, that is the constant pressure that the patient is always experiencing, all right? If you know anything about scalars, and we've talked about this a handful of times, it's why the pressure scalar doesn't go back down to 0. If this is the pressure over time scalar, and let's just say it's in volume control, you know, each breath looks something like this. Shouldn't be increasing in size, but this is 0, and this line never goes to 0, right? Because this is the PEEP. It's the end-expiratory pressure, the pressure that is always there. And most times, the PEEP is going to be somewhere between 5 to 20, and this is millimeters of mercury. And 20 of PEEP is a lot. 5 of PEEP is very minimal. And you can go less than 5, but it's not common. 5 is usually the smallest amount of PEEP that you will set. And the PEEP helps with oxygenation, all right? If someone is hypoxic or they have low oxygen, increasing the PEEP may help them improve their oxygenation, all right? And we'll talk kind of more about that. The FiO2 is the fraction of inspired oxygen, right? FiO2, fraction of, I guess I don't need to do that for every single one, huh? Fraction of inspired oxygen. And this is the percent oxygen that the patient is getting with each breath. And if we think about what this really means, atmospheric oxygen, just what we all breathe in at, I guess, sea level, is 21% oxygen. So on the ventilator, we can set the oxygen anywhere from 21 to 100%. Right? Because 21 is just atmospheric oxygen. Many people don't go less than 40%, but you can. There's no reason you can't. I traditionally have not seen anyone go less than 30%, but you theoretically could go all the way down to 21% or atmospheric oxygen. And this also helps with oxygenation, right? If you are hypoxic or have low oxygen levels and you have to go on a ventilator, we can increase the amount of oxygen you're getting with each breath all the way to 100%. Right, up from 21%, which is what you were breathing on room air. All right, the respiratory rate is the number of breaths you're getting per minute. So someone who's just existing out in the world is usually breathing somewhere between 12 to 16 times per minute. But you can set the respiratory rate at whatever you want. We very rarely go less than 8, and even 8 is incredibly low. There's some complex reasons you sometimes will go that low if someone has a very prolonged expiratory phase and breath stacking and all that kind of stuff. We actually covered that in one of the videos up here, auto PEEP, breath stacking, air trapping. So check that out. We'll link it in the video description. And the respiratory rate can go as high, most people don't go above 32. Not to say, you can't, but you probably shouldn't, because again, you start to get breath stacking things. 32 is very, very high. Normal, as we said, NL normal is somewhere about 12 to 16 breaths per minute. So you're controlling how many breaths the patient is getting per minute. The thing about respiratory rate is that most of these modes of ventilation let the patients take breaths to prompt a breath. So the ventilator will kick in and give a breath if the patient is not meeting the respiratory rate that you set. And the respiratory rate helps with ventilation, right? Which is breathing off the carbon dioxide, because that depends on how many times you're breathing per minute, how many times you're blowing off carbon dioxide per minute. All right. And then the tidal volume, tidal volume, is how many cc's or milliliters of this FiO2 you sent that the patient is getting per breath, right? So the tidal volume, normal, most people do it cc's per kilogram of body weight. So normal is going to be 6 to 8 cc's or milliliters per kilogram of ideal body weight. So ideal body weight based on a person's height rather than their actual body weight. So let's just say you set this to it's really dependent on how tall someone is, but I think for the sake of generalities, 350 to 550, most people are going to fall within that realm. Some who are super short might be less than that. Some who are super tall might be more than that. But the tidal volume is the cc's or milliliters of air you're getting per breath on the ventilator. And you set the tidal volume only when you're in volume control, and we've talked about this a number of times. So the two main modes of ventilation are volume control and pressure control. In volume control, you're setting a tidal volume. In pressure control, you're setting a pressure above the PEEP, because we said the PEEP is there all the time. Positive end-expiratory pressure. It's there no matter what. In pressure control, you set the inspiratory pressure above the PEEP, aka you're telling the ventilator every breath I want you to push this pressure in, and whatever tidal volume that creates is what it creates. So if I set it to 20, what that is meaning is I'm telling the ventilator with every breath I want you just to put 20 millimeters of mercury of pressure into that tube, and whatever pressure that leads to the lungs, whatever volume that leads to the lungs inflating is just what it is, right? And this is usually pressure control above the PEEP. And, there isn't a normal necessarily. You typically don't want to go for both PEEP and pressure control combined, so adding these together above 30, but you can. It's not a law you can. It just might cause some barotrauma and things. So that's pressure control above the PEEP, or the inspiratory pressure is the millimeters of mercury that the ventilator is pushing with each breath. And as we've talked about in different videos, previous videos that you can check out, when they're in a pressure control mode, you're not able to set a tidal volume, right? The four settings would be PEEP, FiO2, respiratory rate, and pressure control above the PEEP. When you're in volume control, you don't set a pressure above the PEEP. You just set the PEEP, FiO2, respiratory rate, and tidal volume, right? So these, this box here is going to be either tidal volume or pressure control above the PEEP, depending on if you're in a volume control mode or pressure control mode. All right. The mode of ventilation is typically on the ventilator somewhere, often in the top left corner, and it'll say, volume control, pressure control, so maybe VC, maybe PC. And then the top right corner typically will give you a peak pressure, which we can dive into in a future video. But the peak pressure is often, if you're in pressure control, the peak pressure will often be this number. If you're in volume control, the peak pressure will be the pressure created when the ventilator pushes in that tidal volume you set. So again, probably for a future discussion. But these are the four basic or 5 basic settings for all ventilators. We should say, apologies, that the tidal volume also helps with ventilation, right? Because if I'm setting a higher tidal volume, it means there's more cc's of gas exchange going on to help you breathe off carbon dioxide. And you might hear this sometimes, but the respiratory rate times the tidal volume is something called the minute ventilation, or how many cc's of air they get per minute, right? The minute ventilation. So that might be something you all have seen before. All right, thanks for sticking around. So assist control volume controller, or ACVC, or assist volume control, AVC, or simply volume control. And this is what it's often referred to in the clinical arena, and that's what we're going to use for the rest of the video, is just call it volume control, although we're talking about assist control, volume control. And we're going to use scalars to understand this. But before we dive into that, we wanted to just talk about volume control, what that meant. So this is a mode of ventilation. When you intubate someone and put them on a ventilator, you can select the mode, the way in which the ventilator is delivering that patient's ventilation. And when we talk about modes of ventilation, for most modes, and most primarily being the two we use most often, volume control and pressure control. Volume control, which we're talking about in this video, and as the name implies, is where you control the volume. Makes sense. Pressure control is where you control the pressure. So in these two different modes of ventilation, the difference in what you set is in volume control, you set a tidal volume, and in pressure control, you set an inspiratory pressure. And what this means is the thing you're not setting in that mode is the uncontrolled variable. So in volume control, you're controlling the tidal volume the patient is getting with each breath, or the cc's of oxygen that the ventilator is pushing into the lungs with each breath. That's the tidal volume. But what you're not controlling, the uncontrolled variable that results from this, is the pressure, the inspiratory pressure, the peak pressure in this case. In pressure control, you're controlling the pressure. You're saying, hey, ventilator, with each breath, I want you to give a set pressure. What is uncontrolled, though, is then the tidal volume, and we'll put uncontrolled for these, because that's the uncontrolled variable that results from the pressure you set. So what this means is there's kind of 4 main settings on a ventilator. There's certainly many more, lots of complexity there. But the 4 main settings, 3 are shared between these 2 modes of ventilation, and that is PEEP, or the positive end-expiratory pressure, that is the FiO2, or the fraction of inspired oxygen, and that is the respiratory rate, or how many breaths per minute the ventilator is delivering. And these 3 are on both volume control ventilation and pressure control ventilation. And you're choosing these. You're saying, I want a PEEP of 5, an FiO2 of 60%, a respiratory rate of 20, or whatever you choose. And we're not going to be talking about each one of these in this video, although we certainly will in a future video. So definitely subscribe and stick around for that. The 4th setting on the ventilator is what's going to be different between volume control and pressure control. And for the sake of this video, again, we're going to do a video on pressure control, but this video we're talking about volume control. So what you're setting here is the tidal volume. And the tidal volume is the cc's, or milliliters, of air that the ventilator is going to deliver per breath. So if you're in the clinical arena and you're setting a tidal volume, it might be, I want the patient to get 400 cc's per breath, 400 cc's of air, or 500, or 350, or what have you. And that is volume control ventilation. What makes it different? Many things. But in the settings, what makes it different from pressure control is that you're setting a tidal volume that you want the patient to get with each breath. Now, ventilators are smart. There's lots of algorithms these days. Let us mute that. And the ventilator is not just going to give this tidal volume every time. The patient has some control over this, because the ventilator is not just going to push this in no matter what, right? There's going to be some variability from breath to breath depending on if the patient is, accepting that breath, or if they're not very accepting of that breath. But about this tidal volume the patient will get with each breath. And that affects our scalars. So when we're talking about volume control, you're going to see the front of a ventilator. So let's say you got a patient here, stick figure human, and they are intubated, unfortunately. They have bad pneumonia, so they have a breathing tube coming out of their mouth, and that breathing tube is hooked up to a ventilator, and you have the ventilator screen. And every ventilator is different, but a lot of ventilators have these 4 settings on the bottom of the ventilator. All right, they have the PEEP, the FiO2, the respiratory rate, and then this 4th setting, if we're in volume control, so if this is ACVC, this is going to be the tidal volume. And as we said, the uncontrolled variable here is the pressure. So often in the top right corner, you'll have a peak pressure, which is the pressure that the ventilator is experiencing each time it pushes in this tidal volume, or the cc's per breath of air that you're setting. And on the front of the ventilator, oftentimes they show scalars. And these scalars are usually pressure over time, flow over time, and volume over time. And these scalars are going to look different depending on what mode of ventilation you're in. And it is important to understand how they differ with each mode of ventilation, and you can also identify the mode of ventilation a lot of times looking at the scalars. So that's what we're going to talk about next in the video, is the scalars that you will see in volume control, or assist control volume control. The first one here is pressure versus time. So pressure on the y-axis, time on the x-axis. The second is flow over time. And the third is volume over time. And in volume control, the scalars you see are determined by how the ventilator is delivering the breath. All right? The volume scalar is the easiest to understand, so that's what we'll start with. So what you have with each breath, this is a single breath here. So this is one breath. And as you can see, the volume goes up for half the breath as the ventilator is delivering that breath, and then it goes down for the other half, right? That's as the patient is expiring. So this is inspiration, this is expiration. And this volume should be about what you set on the ventilator. It should be about that tidal volume. So if you set 400 cc's, each one of these breaths should be about 400 cc's of air. And you can see that repeated, right? Inspiration, expiration, inspiration, expiration, right? And this should be about 400 each time. And this would be 3 breaths, right? 1 breath, 2 breath, 3 breath. And this looks similar between volume control and pressure control. You get about, the tidal volume is going to be different, but the scalar itself, the shape of it, inspiration and expiration, is about the same, right? Because the volume goes up when they inspire, the volume goes down when they expire. And it goes, hopefully, to 0, right? Because you hopefully breathe out all the air you breathe in. And then when there's no air going in, when they're between breaths, you just have this volume at 0 because they're between breaths, right? Breath 1 in, breath 1 out, no breath. Breath 1, breath 2 in, breath 2 out, no breath. Breath 3 in, breath 3 out. So that makes sense, right? That's an easy one to understand. What about these other 2 scalars, though? You have flow and pressure. So as we said, when the ventilator delivers a certain volume, the ventilator is going to experience a pressure, right? Because if you push air into the lungs, there's going to be a pressure that develops that the ventilator senses while it's pushing that air in, all right? And that's going to vary depend on the cycle of the breath. But something to know about volume control is even though you're setting a tidal volume, the ventilator is actually targeting a flow. And this is going to make sense in a second. So if we talk about ventilators, oftentimes there's 3 things we think about with each breath. The trigger, or when the ventilator decides to give a breath. The target, or what the ventilator is targeting, because it needs to target something, right? It's a ventilator, it's not a human, it can't think. So you have to tell the ventilator, I want you to target X with this breath. And then the cycle, or when the ventilator stops the breath. So the trigger, when the ventilator decides to start a breath, the target, or what it targets during that breath, and then the cycle, when it decides to stop a breath. And in volume control, the trigger is time. Makes sense, right? We said we set a respiratory rate. If we set the respiratory rate at 20, that means that every minute, every 60 seconds, the ventilator is saying that that patient needs to get 20 breaths every 60 seconds, or about 1 breath, right, per every 3 seconds. And ventilators are smart now, and this is assist control, meaning the patient can also take their own breaths, and that counts towards the 20. But if the patient is not taking their own breaths, every 3 seconds, the ventilator says, I need to give a breath, or that's my trigger. If there's not been a breath in 3 seconds, that triggers me to give a breath. So time is what triggers the ventilator to start a breath. We're going to skip target and come back to it and go with cycles. So what then causes the ventilator to stop a breath is the tidal volume, and what the ventilator targets is the flow. And this is where things get confusing, but if you understand this, you'll understand the scalars, or possibly vice versa. So let's pause. I told you in volume control, you're setting a tidal volume for the ventilator to give with each breath, right? But I just then told you that the ventilator's targeting a flow. Well, what's that about? Why wouldn't it target a tidal volume, right? If I said, give it a certain tidal volume, why wouldn't it just target the tidal volume? Well, it is in a way, but it's in an indirect way, because what causes the ventilator to stop a breath is the tidal volume. So if I tell the ventilator I want that person to get 400 cc's of air with each breath, the ventilator says, okay, I get that. I am going to target a flow. So flow is the amount, it's like cc's of air per unit of time. So if I say I want the patient to get 400 cc's, let's just do 500 because it's an easier number. The ventilator goes, no problem. I know that if each breath that I'm giving, I'm just making up numbers here, each breath that I'm giving is going to be 1 second long, and I need to give 500 cc's, I know how much air to flow in that second. It's 500 cc's per second. Let's just say the breath is going to be 2 seconds long, right? So if the breath is 2 seconds long, the ventilator says, no problem. 500 over 2 seconds is going to be 250 cc's of air per second. And that's what I'm going to flow in, because this is, air cc's per unit time seconds. So what the ventilator actually targets is this flow. It's the cc's of air per second, because it knows then that it will give the tidal volume I'm setting over the duration of that breath. So it will give 250 cc's per second for the 2 seconds until it gets to the tidal volume I set of 500 cc's, right? 250 times 2, and then it will cycle. It will say, stop the breath. That's the tidal volume they wanted. Breath is over. And this then translates into why our pressure and flow scalars look the way they do. Because if you look over here and start with flow, what you see is flow is flat on the top, whereas pressure ramps up at the top. Now, why would that be? Because we are targeting a set flow. So over time, right? So the ventilator says, okay, 250 cc's per second of flow. I'm going to just ramp up immediately to that set flow of 250 cc's over, 1 second time, and then the flow just immediately goes to 0. This is inspiratory flow. And then this is negative because the patient's starting to expire. So this portion here, the positive portion, is inspiration. This portion here goes all the way down to the negative portion is expiration, because this here is 0 flow. Right? So now there's no flow when the breath is done being expired out until they inhale. You get your set flow rate. It holds that flow, 250 cc's per second. Okay, I got my tidal volume. I got to my 500 cc's of tidal volume. I'm going to just drop the flow, right? It just goes all the way back down to 0. But then the patient starts to breathe out and expire until it goes back to 0 when the patient's breathed all the air out. Right? And that's why in volume control, this top area is flat on top, because the target is a flow rate. It's a constant flow rate until you get to the tidal volume that you set, and at which point the ventilator stops flow and the breath is over. And that's also why you get this ramped up pressure, because if you give a set flow rate, it's going to slowly build up the pressure in the lungs. Right? You got 2 lungs here. You got a trachea that goes into these lungs, and I'm pushing air in, and that air has to expand the lungs. But the lungs, they have a compliance, right? It takes effort to expand those lungs and overcome the lungs' compliance, but that in turn creates pressure pushing back, right? Because those lungs are expanding and kind of pushing back as they expand. And that's what causes the pressure that is created. And, peak and plateau pressures and things is going to be a different video. But when you set a set flow rate, that's going to slowly, as it flows air down and pushes those lungs out, build up an increasing pressure as more air is delivered into the lungs until you get to that point where the breath is done. You can see these line up, right? Breath is done, at which point the patient expires and the pressure drops back down to this set pressure, which if you watched our original video, this is the PEEP, the positive end expiratory pressure, which we won't go into here. Definitely check out that other video. And as you'll see, and we're going to link all these in the video description when we talk about pressure control scalars, this looks different than a pressure control scalar. This ramp up is characteristic of volume control because you have a set flow rate, and as that flow over a period of time, let's just again make it up, say it's 2 seconds, for every 1 second it's kind of pushing in 250 cc's per second, or you could break this down even further into milliseconds, but it's flowing a certain volume of air in per millisecond, and that is slowly filling up the lungs, increasing the pressure until that breath is over, at which point the patient expires and the pressure goes back to the end expiratory pressure that we set on the ventilator. All right, so this is very characteristic of volume control. You get this flat top at your flow scalar, you get this ramped up pressure scalar, and then the volume scalar is pretty constant between pressure control and volume control. It's pretty constant. All right, thanks for sticking around. So today we're going to be talking about assist control pressure control, also known as ACPC or assist pressure control, or many people in the clinical arena just refer to it as pressure control, and that's what we're going to refer to it as for the rest of this video. And we're going to talk about it in relation to the pressure time scalar, the flow time scalar, and the volume time scalar. Before we do that though, we wanted to talk a little bit about pressure control. So on a ventilator, there's lots of different things you can set, but the main 4 things that you can set are the PEEP, or the positive end expiratory pressure, the FiO2, or the fraction of inspired oxygen, the respiratory rate, and these 3, we have done this exact same video for volume control. Again, we'll link it in the video description. These 3 are all present in both pressure control and volume control, right? Volume control being you control the volume, and the uncontrolled variable is the pressure, whereas pressure control, you control the pressure, and the uncontrolled variable is the volume. And we'll talk more about this in a second. But in both of these modes of ventilation, these 3 settings are the same: the PEEP, the FiO2, and the respiratory rate. The setting that is different between the 2 is the 4th. And in pressure control, you're setting the inspiratory pressure, whereas in volume control, you're setting the tidal volume, or the cc's of air that is being pushed into the lungs with each breath. So this is volume control. In pressure control, you're setting the inspiratory pressure. And what you're saying, what you're telling the ventilator is you're saying, listen, with every breath, I want you to give this pressure, right, this millimeters of mercury. And that pressure is going to create a tidal volume. The tidal volume is the cc's, or milliliters of air the patient gets with each breath. That's the tidal volume. So the inspiratory pressure you're setting is going to create a tidal volume, but the tidal volume created is going to be very patient dependent, right? It's going to be based on the patient's anatomy, physiology, their lung compliance, all these different things. So this is the uncontrolled variable. This is the result of the inspiratory pressure you set. The nice thing about pressure control, though, is that the ventilator, it won't go above this inspiratory pressure, usually. So if you're worried about, barotrauma or certain damages from high inspiratory pressures in volume control, because in volume control, you're setting the volume here. And the pressure that results from that volume is uncontrolled. You're saying, I want the patient to get 500 cc's per breath of tidal volume, and whatever pressure that takes is what that pressure takes. In pressure control, you're saying, I want the patient's lungs to just get this pressure. And whatever tidal volume that pressure creates is the amount of tidal volume they'll get with each breath. All right, so the tidal volume is a result of the inspiratory pressure you set. So there's nothing in here where you're setting a tidal volume. You're setting an inspiratory pressure, and whatever volume results from that with each breath is the volume that results with each breath. And you can go, let's say they're getting too much tidal volume, you set the inspiratory pressure at 30 millimeters of mercury, and it's resulting in a tidal volume of 700 cc's per breath, and you're like, that's way too high. Well, you can go down, right? Maybe you'll decrease the inspiratory pressure to 20 millimeters of mercury. And that pressure being lower, you could picture, right? If you're pushing in less pressure, the tidal volume is going to be lower. Maybe the patient then gets 500 cc's per breath. And most of the time, and this is ventilator dependent, most of the time this is the pressure above the PEEP. So let's say I set this at 15 and the PEEP is at 5. That means the total pressure they're getting with each breath is 20, 15 plus 5. Again, a little ventilator dependent. Okay, so you're setting an inspiratory pressure in pressure control. You're controlling the pressure. How do we understand that with the scalars? Well, the scalars look different in pressure control than they do in volume control, or a different mode of mechanical ventilation. And that is based on 3 different things, right? Anytime we're thinking about a mode of mechanical ventilation, a way we can help to understand it is based off of what the ventilator does with each breath. And what creates a breath? Well, for the ventilator to create a breath, there has to be something that triggers the ventilator to give a breath, right? So that's how the ventilator decides it needs to start a breath, because this is a machine. It's not thinking for itself. You need something that triggers the ventilator to give a breath. You also need the ventilator to target something, right? It can't just push in air randomly, right? It has to target something. And then you need the ventilator to cycle or to end the breath, right? And all these are things that the ventilator isn't thinking about. It's not, you need to set this. And in pressure control, these 3 things differ than volume control. So in pressure control, the thing that triggers a pressure is the time. And this is actually the same as volume control. So you set a respiratory rate at 20, and the patient can take breaths that count towards that 20. But let's say the patient isn't taking any breaths. 20 breaths per minute, that means 1 breath every 3 seconds. And if the patient doesn't breathe in 3 seconds, that triggers the patient or the ventilator to give the patient a breath. So time is the trigger. Every 3 seconds, that patient should get a breath, because I set the respiratory rate to 20 breaths per minute. And in pressure control, the target is the pressure you're setting. So you're setting a pressure, again, let's say it's 20, and you're telling the ventilator that you want them to give 20 millimeters of mercury with each breath, and that's what the ventilator is going to target. It's going to target 20 millimeters of mercury. All right, so then how does it cycle? How does it end the breath? Well, time as well. Because each breath, and this is a more advanced setting, but each breath only lasts a certain amount of time. Right, so let's just say, I'm just making this up for the sake of easy numbers, but let's say that you said the breath can last for 2 seconds. Right, the ventilator will cycle or end that breath at that 2 seconds that you set it. And ventilators are smart. They let the patient also contribute to some of these things if the patient wants a longer breath or a shorter breath, but not to too much, because this is ventilator desynchrony, which we talked about in some of these other videos that we'll link in the video description. It can cause ventilator desynchrony or the patient not cooperating with the ventilator. But in pressure control, the target is what you set, right? It's going to target a certain inspiratory pressure. So if we think about the scalars then, if we go down to the scalars, this is the pressure on the y-axis versus time scalar. This is 0 pressure, and then this is all time. This is the flow versus time scalar. This is 0 flow. And this is the volume versus time scalar, and this is 0 volume. The volume versus time scalar is very similar for all intents and purposes. It's pretty much the same. It has the same look between volume control and pressure control. All right, it looks the same. And what it is this is a single breath. Every triangle is 1 breath. And what happens in this breath is the volume goes up, right? It's positive. This is inspiration, or this is when the ventilator is giving a breath. And you get to whatever you set, right? 400 cc's, 500 cc's the tidal volume, and then the volume starts to go down. That's when the patient is expiring or breathing that air out, right? And this is going to be your whole breath, your tidal volume, 400 cc's. They inspire to 400 cc's and then they breathe it out. And it should go back to 0 after each breath, because you are expiring the same amount of tidal volume that you inspired. And if this doesn't happen, you can get breath stacking and some of these other things. We actually made a video on it. We'll link it in the video description. Auto PEEP, breath stacking, air trapping, where we talk about what happens when you're not expiring all the air each time. Yeah, and that's each breath, right? This is breath 1, breath 2, breath 3. You inspire, right? Ventilator gives the breath, then you expire or breathe out all that air, it goes back to 0, and this is your tidal volume, or how many cc's of air you're getting with each breath. Same thing, inspiration, expiration. And these, again, look the same between volume control and pressure control. The pressure and flow scalars look different between the two, though. And this is what pressure controls looks like, and it's all about the target, right? In pressure control, you're targeting a pressure. So you get this flat top because you're saying, I want it to be 20, right? So the ventilator says, great, this here, 20. So the ventilator cranks up the pressure with each breath to 20, and it just leaves the pressure at 20. So you get this flat top, and that's just sitting at an inspiratory pressure of 20. And then when the breath's done, it drops back to not quite 0 here, because this is the PEEP, which we talked about in that other video that we mentioned, the introduction. So we won't go into it here as much. But every breath, right? So that's breath 1. Breath 2, it goes straight back up to that inspiratory pressure of 20 you set. It leaves it there for the whole breath, and then it drops back down to the PEEP. That's breath 2. Same thing for breath 3. And that's why you get this flat top, because it's a constant pressure that you set, right? You're like, I want this pressure to be 20 millimeters of mercury for the whole breath. That's what the ventilator targets, and that's what it keeps it at for the duration of the breath. There's no in between, you know, it doesn't ramp up and ramp down. It just goes straight up to 20 because that's what you set. It stays at 20 for the breath. When the breath's done, it goes back down, right? Breath starts again, straight up to 20, stays at 20 for the whole breath, back down. The flow that results from that looks different in pressure control than volume control as well, right? The flow here is going to be dependent on how that pressure was given, right? So the pressure just ramps up to the pressure of 20. So flow starts at 0, right? This is when there's no breath being delivered. There's no inspiration or expiration going on. And all of a sudden the ventilator gives the 20 millimeters of mercury and the flow goes way up, right? And then it stays at 20. So if you picture what this looks like, because this is, the pressure doesn't slowly ramp up. The pressure just goes to 20 and keeps it there. So that initial up to 20 creates this steep upslope for flow. And then as it holds it at 20, the flow actually starts to slowly decrease. It's still positive. You're still getting flow into the lungs, but it starts to decrease up until that breath is done, right? So this here lines up with when the breath ends. So at this point, there's no more inspiratory pressure being given. So it drops down to negative flow because the patient starts to breathe out. So this here is inspiration. This here is expiration because the patient is breathing that air out. So there's negative flow, inspiration, and then I'm blowing out expiration. So there's negative flow up until the breath is over. And then there's 0 flow because there's no inspiration or expiration. And same thing, the pressure starts, it gives a pressure to 20, so the flow shoots up quick. The pressure then stays at 20. So you're still getting a breath in, but it's not, you initially get a, and then you start to keep that pressure constant. So the flow slowly decreases while it's still going in until the breath is done. And then you start to expire. Right? So inspiration, expiration, inspiration, expiration. And that's why you get this triangle flow for pressure control, because you're getting this set pressure that's cranking up to the pressure you want, and then it's staying there, right? That's the pressure scalar staying there. And as it stays there, you don't get this huge increase. The flow's still positive, but it's kind of ramping down until that pressure's done. All right, so this is characteristic of pressure control. You get the flat pressure top because that's what's targeted. And the flow does this huge increase and then slopes back down towards 0.
All right, everybody, welcome back to another episode here on Whiteboard Medicine. We appreciate you checking it out. Hope everybody's doing well. Today's topic is a potentially intimidating one. It's even maybe a little intimidating to us because it's not a commonplace, but it is a really important topic. It's going to be part of our mechanical ventilation series, an advanced topic, and it's going to be on a mode of mechanical ventilation, a mode called APRV, or airway pressure release ventilation. We're going to dive into all things APRV. Quick disclaimer per usual, none of this is intended to be acted upon as medical advice. Hang out till the end of the video, or look in, video or podcast, or look in the episode's description to check out the full disclaimer. And then a couple shameless plugs. We can't help ourselves. We're sorry. We're excited about things. But we have a Patreon page, the study guide for this video, as well as practice questions, and really kind of every other day posts on different public health and medical education things on there. Check it out. We have a weekly newsletter that's more focused on public health and emerging infectious disease. And we also obviously have a YouTube channel, as well as podcast platforms. All that's linked in the episode's description. We'd love for you to check out some of that other stuff. No further ado, shameless plugs done, into APRV. So what is APRV? This is a mode of mechanical ventilation, again, that's not super common. We don't tend to use it that much in our day-to-day practice, but you will come across it, and it might be something that becomes more prevalent as time goes on. But APRV stands for airway pressure release ventilation. And it's a mode of mechanical ventilation that provides actually continuous positive airway pressure with intermittent brief releases to facilitate ventilation and CO2 removal. We just want to say that again because this is the foundational principle, which will make more sense as we go on. It provides continuous positive airway pressure with intermittent brief releases to facilitate ventilation and CO2 removal. It was originated as this idea that it might have more lung protective, kind of open lung strategy, keeping alveoli recruited, all that good stuff. And it does allow for a patient to take spontaneous breaths throughout the respiratory cycle, even during the high pressure phases, which are things we'll talk about, with some thought that that improves patient comfort and reduces sedation needs. The summary statement on evidence here is evidence is kind of inconclusive, with where this is best used. We're going to talk a little bit about that evidence. So some of the claims here are claims based on the physiologic rationale for APRV rather than kind of a robust randomized control trial evidence base. But we'll point that stuff out as we go through. So how does APRV work? Well, the first concept to think about is it involves actually two different pressure levels, a P high and a P low. And you set these. The P low is often 0, right? 0 centimeters of water. And the P high is something that you'll set, and we'll talk more about that. Because what you're going to do is the patient is going to spend most of their time at P high, which means most of the respiratory cycle is the ventilator is giving the patient the pressure you set for P high. And the thought is that that maintains alveolar recruitment and also helps oxygenation. But at regular intervals, which we'll get into, the ventilator will briefly drop the pressure to the P low for a short amount of time. And by dropping from P high to P low, you're going to essentially have that patient increase their exhalation, which will help with their ventilation, allow for CO2 removal. And we'll talk more about this. This will all kind of start to add up as we go through things here. Okay, so the concept is a patient spends most of their time at this high inspiratory pressure, this P high. And at certain intervals that we'll get into that you set, the ventilator drops them down to a lower pressure, a P low, to allow them to exhale and allow that CO2 to be removed. And the second part of this concept is the time, because in addition to a P high and P low, you're going to set a T high and a T low. The T high is the duration the patient is at their P high. Okay, we want to say this again because these terms are all kind of starting to overlap. You're going to set a pressure high, that's an inspiratory pressure, and then you're going to set a T high. The T high is the amount of time the patient spends at P high. And this might be something like 4 to 6 seconds, okay? You're then going to set a T low. This is the amount of time the patient spends at, you guessed it, the P low. And this is often a lot shorter. It's often very brief. It might be something like 0.5 to 1 seconds. So now let's start to tie these together. You set a P high and a P low. Okay, let's just make something up. We said the P low is 0. Let's just say the P high is, I don't know, 20, which is maybe not super realistic, but the P high is 20, the P low is 0. The T high is, let's say the T high is 5 seconds, and the T low is 1 second. So what essentially the ventilator is going to do in APRV is it's going to put the patient at P high, that 20 centimeters of water that you set, for 5 seconds. And after 5 seconds, it's going to drop the patient to the P low, that 0 centimeters of water that you set. You set the P high and the P low, and it's going to put them at P low for the T low, which we said is 1 second. So for 1 second, they'll be at P low, and then the ventilator will go back to P high. You set the P high at 20, so they're at inspiratory pressure at 20. You set the T high at 5 seconds, so they're at that P high for their T high. They're at 20 for 5 seconds. After that 5 seconds, again, the ventilator drops the inspiratory pressure to P low, which is set at 0. And they'll stay at P low for the T low, the time low which you set, which you made 1 second. So for P low, for T low, the P low is 0, the T low is 1 second, so they're going to be at 0 for 1 second. After that 1 second's out, then it goes back to the P high for 20. For the duration that is T high for 5 seconds, before it drops back down to the P low, which is 0, for the duration T low, which is 1 second. And the cycle goes round and round and round. We hate to be repetitive and repeat it over and over, but this is confusing with the verbiage used, and also critically important. Okay, so you set the P high, the P low, the T high, and the T low, and the ventilator cycles through those. The other thing that this allows, which we did have mention, is the patient is allowed to spontaneously breathe throughout the respiratory cycle. So although the ventilator is cycling from P high to P low, and how it decides when to cycle is based on what you set for the T high and the T low, but throughout this whole time, the patient can take their own spontaneous breaths. So if I'm a patient and I want to take an additional breath, I just take a breath. And the ventilator lets them do that, okay? And there's some argument that that helps with comfort, decreases sedation, all that kind of stuff. So it does allow for spontaneous breaths, even while the ventilator is kind of walking them through from P high to P low, back to P high to P low, back to P high to P low, for the duration that is T high to T low. So typical APRV settings, what do we usually set these different things at? If you're watching the video, we have parameter, initial setting, and then some notes, but we'll also kind of verbally walk everybody through it. So the PI is typically set anywhere from 20 to 30 centimeters of water. You can think of this kind of like a plateau pressure in conventional modes. This is meant to maintain a degree of alveolar recruitment. So it's an inspiratory pressure that you're setting, and this is the PI, the highest pressure that patient's alveoli will feel. So usually 20 to 30 centimeters of water is a typical starting P high. And then the P low tends to be started at 0 centimeters of water. And this allows for that pressure release that allows them to go from a high inspiratory pressure down to a low inspiratory pressure to then help them blow off cc's of air or tidal volume to then ventilate to improve their carbon dioxide. The typical T high usually is 4 to 6 seconds. This is the time in which the patient is held at that P high. A longer T high does improve mean airway pressure and can improve oxygenation because they're at a higher pressure for a longer period of time. The T low is usually, 0.5 to 1 seconds. And again, the T low is the time in which the ventilator lets the patient be in their P low, or their low pressure, or that 0 centimeters of water. This must be short enough to prevent full exhalation. Why? So when you go from P high to P low, you're essentially letting that patient exhale. But you don't really want them to fully exhale, because if they fully exhale, that can lead to de-recruitment. So you don't want the T low to be a duration of time that allows for full exhalation. You can look at kind of the expiratory flow curve, and you want it to be a little shorter than full exhalation to avoid de-recruitment. And then you also are going to set the FiO2, which usually start 100% and titrate down to get to adequate SpO2 goal. But in in APRV, the 4 settings that are probably going to be unique and somewhat confusing for people that have not done it before are going to be the P high and the P low. P high 20 to 30 centimeters of water, P low 0 centimeters of water, the T high and the T low. T high usually 4 to 6 seconds, T low usually 0.5 to 1 second, with the goal being to not allow full expiration before you cycle back to the P high. All right, that's a lot. Hopefully that made sense. We try to repeat things, 89 times with the hope that it would be less confusing rather than more confusing, but let us know. All right, possible indications for APRV. When could you think about using it? And remember, we said, the evidence here is vague at best. It might be helpful for some things, but we don't really know. So we did put this disclaimer, no strong evidence for utility of APRV, but there are some smaller trials. These smaller trials have focused on things like ARDS, acute respiratory distress syndrome. There's some people out there using APRV for ARDS. Refractory hypoxemia, not responsive to conventional ventilation, because you're keeping these pressures, these patients, for longer periods of time in a higher inspiratory pressure, that P high, which can help with oxygenation. Patients who benefit from spontaneous breathing, right? We said that during APRV, the ventilator lets patients take their own breaths as well. So if a patient is having a lot of ventilator desynchrony, some people think that this mode actually helps with ventilator synchrony by allowing patients to take spontaneous breaths. And then there's an idea that this might be a more lung protective strategy in certain patients, so that's a consideration too. But again, no super strong evidence in any of these, at least at the time of this video recording. Contraindications are arguably more important because you can do harm with this mode of ventilation, okay? Patients with severe obstructive lung disease, they don't have the ability to adequately ventilate in APRV. Right? We came out with a video on mechanical ventilation strategies in obstructive lung disease. Definitely check that out if you have an interest in this topic, because as we know, patients with obstructive lung disease have a really prolonged expiratory phase. They need a lot more time to expire all their air because they have all that small airway disease that causes obstruction. And as we said, T high and T low, T high tends to be 4 to 6 seconds, and T low tends to be 0.5 to 1 second. And this is when you're letting the patient breathe air out when they're in T low. And as such, that's a really short expiratory time. So these patients really will get air trapping, they'll get breath stacking, auto PEEP, they'll get more hypercapnic. This is not a good modality for ventilation in patients with obstructive lung disease. Patients with high intracranial pressure, people say, that APRV can lead to higher mean airway pressures that may impair cerebral venous return, so keep an eye on that. Patients with uncontrolled spontaneous breathing with poor synchrony. If you have a patient who's just, ventilating like mad, taking these crazy breaths, they probably won't get along with APRV. Although patients who have controlled spontaneous breathing rather than kind of uncontrolled huge breaths all over the place, those patients might do okay. But uncontrolled spontaneous breathing, they may not get along with APRV. And then hemodynamic instability, you're keeping these patients with high inspiratory pressures, that P high, for longer periods of time, aka that T high, and this can lead to some reduced venous return theoretically. Probably not as clinically relevant, but is something that people talk about. Potential complications of APRV. So pneumothoraces, anytime you have someone who you're kind of keeping them at higher pressures, that can lead to barotrauma pneumothoraces. Volutrauma from overdistension if you're not really titrating that P high adequately. Auto PEEP can happen if that T low is too short. So this can be really hard to kind of navigate perfectly because if that T low is too short, so they don't have enough time to expire before you put them back to P high, they can auto PEEP. But at the same time, you don't want them to fully expire, exhale all their air when they're in T low because you don't want them to de-recruit. So you're trying to walk this fine line, which is why this can be a difficult modality for mechanical ventilation. People say those with really severe hemodynamic compromise may not do well with APRV because of elevated intrathoracic pressures. Again, this is maybe less of a thought, but definitely something to keep in the back of your head. Patient discomfort. and desynchrony can happen in APRV just like anything else. And then delayed CO2 clearance. This is not a mode that has great ventilation for CO2 removal. This is a mode that has good oxygenation. So if CO2 is the main problem, you do not want to use APRV. How do you monitor and adjust APRV? Okay, we're getting towards the end here. So obviously assess the oxygenation. You can do that with a blood gas. You can do that with oxygen saturation, to make sure they are adequately oxygenating. If they are not, you can consider increasing P high depending on what you're at, but you don't want to go above 30. You can consider increasing T high to keep them at their P high longer, or of course you can increase the FiO2 as long as you're below 100%, because that's the most you can give. Adjust CO2 clearance. So to clear more carbon dioxide, you want to shorten T high. This will allow more frequent releases to P low, right? Because P low, when they go from P high to P low, that's when they ventilate. That's when they exhale. So if you shorten T high, which is the amount of time they're in their P high, that means they'll cycle to P low more often and exhale more often and release more CO2. You can also slightly prolong their T low, right? That's the amount of time they're at their P low, which allows for a little more expiratory time. Although again, like we said, you don't want them to fully expire and then de-recruit. Monitor their expiratory flow. So ensure that the T low ends before they have fully exhaled. Most people say to kind of target this 50 to 75% of a full exhalation, because you don't want that T low to be for 100% of their exhalatory phase, because they'll de-recruit, but at the same time you don't want the T low to be too brief, because then they will become more hypercapnic because they'll have less time to exhale air and exchange gas. Watch for auto PEEP. Make sure that they have enough time to exhale at least some air before you put them back into P high, and that's going to be an adjustment to T low. You might need to increase T low, so increase the length of time they're at their P low to let them exhale more air if they're starting to auto PEEP. And then you can gradually wean this, and this is actually kind of nice. You can gradually lower the P high and increase the T high, and that kind of converts it into CPAP to a degree, right? If you march this P high down all the way to a P high of 5, and this T high you march up to, most of the respiratory cycle, that essentially just means they're at a 5 a PEEP. That's kind of like CPAP. And that helps with some weaning trials. Okay, getting to the end here. What are the key concepts to remember? So APRV, it's time cycled and pressure controlled. Time cycled meaning you have a certain amount of time at their P high and a certain amount of time at their P low. Pressure controlled meaning you set the P high and the P low. You're not setting a tidal volume. So it's time cycled and pressure controlled. It promotes alveolar recruitment, improves oxygenation usually, and does allow for the patient to take spontaneously breaths during APRV. The goal here is to maintain open lung ventilation, right? Keep things recruited. It may be useful in early or moderate ARDS, but we don't have firm evidence on this yet. I'm sure people are studying it. It does require close monitoring, and it does require understanding respiratory mechanics. This is not a modality to just kind of fiddle around with, right? Patients get profoundly hypercapnic. Patients get really high intrathoracic pressure, which can lead to hemodynamic instability, which can lead to pneumothoraces. This mode is not always forgiving. Now, patients can spontaneously breathe on it, so there's some forgiveness there, but it's not the most forgiving mode.
So, ventilator-induced lung injury, or VILI, V-I-L-I. It also goes by the name ventilator-associated lung injury, as folks didn't want it to seem like it was the ventilator causing injury and that you didn't need the ventilator, because obviously if you're on a ventilator, it means you need the ventilator. You'd be dead without it. So some call it VALI, ventilator-associated lung injury versus ventilator-induced lung injury. But what it is it's lung injury that's induced or associated with mechanical ventilation. And the reason this happens is mechanical ventilation is not a treatment or a curative for any disease. Mechanical ventilation is simply to buy you time. This is where you get a breathing tube. You have endotracheal intubation, you get put on a ventilator. And that ventilator is essentially what oxygenates you and ventilates you. It gets oxygen in your body and gets rid of carbon dioxide. But to put someone on a ventilator means that they have some pathology that is not allowing them to breathe on their own adequately enough. Maybe it's a terrible pneumonia. Maybe you had a surgery on your neck. Maybe you have pulmonary edema, too much fluid. Maybe you had a seizure and you aspirated into your lungs, right? All those things can cause severe hypoxemia. Maybe you have a really bad COPD exacerbation from emphysema and you're hypercapnic, your CO2 is so high. All those things can lead to respiratory failure requiring mechanical ventilation, because the mechanical ventilation buys time while the patient recovers. All right. When you're on a ventilator, though, obviously we see this in the clinical arena. There is the ventilator is not your lungs. It's not your body. It's a machine. And although we do everything we can to optimize that machine, it's still not a perfect modality for patients, because that machine administers air. It pumps air in and out. And on that machine, we do a lot of settings. We've talked about this in our mechanical ventilation lectures, right? We set things like PEEP, or the positive end-expiratory pressure. We set things like FiO2, or the fraction of inspired oxygen. We set things like tidal volume, or the amount of air a patient is receiving with each breath. We set things like respiratory rate, right? The number of breaths the patient is going to get on the ventilator in a minute. There's even different mechanical ventilation settings, right? There's AC/VC, which is assist control. There is AC/PC. Apologies, our computer keeps going dark here. Or pressure control. There's even weird stuff like APRV, SMIV, lots and lots of different settings. So mechanical ventilators are quite complex. And as such, they're not perfect for the lungs. They're needed at times, but they're not perfect for the lungs. And part of that is because you can get ventilator-induced or ventilator-associated lung injury. How does this happen, though? Well, your lungs, just like any organ, have an inflammatory response. They also have tissues. In your lungs, this is what we call an alveolus. Well, I guess this would be alveoli, because it's a bunch of alveoluses together, which isn't a word. So this is an alveoli. And these are very thin-walled balloon structures. Thin-walled balloon-like structures. And these deflate and inflate to help with gas exchange. And they have these capillaries coating them. So the capillaries pump in deoxygenated blood. So that's blood that is low in oxygen and it's high in carbon dioxide because it came from the rest of the body. And those blood vessels reabsorb a bunch of carbon dioxide from muscles and things. And what happens is the capillary pumps carbon dioxide out into the alveolus, and oxygen, right? Because what happens is you have a trachea, bronchi, right, two lungs, and these bronchi break off into smaller and smaller bronchioles until you get to this, which is kind of the distal bronchiole that goes into the alveoli. And what you can see is each alveolus, this is an alveolus, a single alveoli, oxygen is being breathed in to each alveolus, and that carbon dioxide is being from the capillary out into the alveolus. So let's say this again. The carbon dioxide from the body goes into the capillary along the alveolus, and it pumps carbon dioxide into the alveolus. Oxygen from the lungs into the alveolus comes in here and then diffuses into the capillary. So O2 goes into the capillary to then be distributed to the rest of the body, right, to deliver oxygen to the rest of the body. And then all this carbon dioxide now, right, all the oxygen went in to the capillary, all the carbon dioxide went out into the alveolus. We then breathe out the carbon dioxide, which this is a single alveolus, so it would then go into the alveoli, go into the bronchioles, all the way into the bronchi, trachea, and then out the mouth. And you'd breathe that carbon dioxide back out into the world. It's supposed to say CO2. And that process goes on and on and on with each breath. When you're on a ventilator, what's happening is the ventilator is pumping that air in and out of the trachea, bronchi, bronchioles into the alveoli. And what happens is when you have lung disease, you get different areas in your lungs that kind of are patchy and collapsed. And it's really important for this alveolus to be kind of perfectly inflated, because if it's underinflated or if it's overinflated, all this can cause damage to these really thin-walled alveoli. And different parts of the lung experience different pressures. If I have pneumonia in one part of the lung, that might be experiencing things differently than the part of the lung that doesn't have disease. So when you're on the ventilator, patients can get damage from the ventilator by no fault other than it's an imperfect modality to their alveoli. And that is what ventilator-induced lung injury is, because once these start to get damaged, you start to get immune cells that come in here and cause inflammation. You get damaged to these alveolar capillary barrier, that epithelial endothelial barrier. Gets disruption of the tight junctions, destruction of the glycocalyx. You get capillary leak into the alveolus, so then you start to get some proteinaceous fluid in here, and this can eventually be associated with things like ARDS, acute respiratory distress syndrome, which we've talked a lot about. But what types of ventilator-induced lung injury are there? Well, there's several, and the way we like to categorize them is based on the amount of distension of the alveolus. So this is a graphical representation, all three of these, of alveoli and the amount of distension they have, because these are small balloons. So when we take a breath in, our alveoli expand. When you're on a ventilator, you set how much pressure and air someone is getting in. And you want to target this optimal distension of the alveolus. It's like a balloon, right? If a balloon is too filled, you start to put stress on those walls and it can pop. Alveoli don't necessarily pop, but you get the picture. If the balloon's underfilled, it's kind of all collapsed down. And then every time you get a breath, it has to re-expand. So if we think about the different types of ventilator-associated lung injury, the first is something we call atelectrauma. Atelectrauma is from the word, let's see, what color should we use? Let's use this one. From the word atelectasis, which is kind of lung collapse. And atelectrauma happens when the alveoli are not distended enough. They're too collapsed. And what happens is every time you pump a breath in on the ventilator, then they have to kind of open up and expand, and they collapse back down, and open up and expand and collapse back down. And this can lead to damage from kind of shear stresses and things on that thin alveolar wall, as well as neighboring and adjacent alveoli and small airways. And that trauma is called atelectatrauma. Sometimes people call it cyclical atelectasis. And the way to try to improve this, and if this is a concept that is not making sense, what we're about to say, we'll point you to a video on this page that'll help you, but you need to optimize the PEEP. So on a ventilator, we said there's several different things you set. PEEP is one, FiO2 is another one, tidal volume is another one, and a respiratory rate is the fourth. And you can set a bunch of other stuff too, but these are kind of the four main ones. And if you are unfamiliar with these four concepts, we'd encourage you on our page, if you go to that mechanical ventilation playlist, and again, we'll post it on the page. Oop, we're going to play something on accident now. Let's X out of that. And we did it again. Let's see, strike two. Maybe we're just trying to manipulate you into playing videos. No thanks. But there's a basics of mechanical ventilation that explains all of those things. So definitely check this video out and then come back to the ventilator-induced lung injury if this is kind of not making sense to you. So you want to optimize the PEEP, because your goal is you want to try to get that alveolus to a perfect amount of distension. You want to stop under distending it, because that will then help get rid of any atelectatrauma. All right, there's also this concept known as biotrauma. Biotrauma is where the lung, from kind of injury and stress, starts to release inflammatory mediators. And biotrauma can happen even when you're optimally distended, because the immune system goes all throughout the body. So the immune system, if it's activated by something else, still can get to the lungs and cause biotrauma. But biotrauma gets worse when you have ventilator-induced lung injury from other causes. So let's say you have atelectrauma or you have barotrauma, which we'll talk about. That trauma to the alveoli also causes an inflammatory response and more inflammatory mediators. So the treatment for this, and as you can see, we're kind of putting treatments. We put treatments in this blue color. The treatment for these is maybe steroids, right? Steroids might work for biotrauma from ventilator-induced lung injury. And that's somewhat extrapolated from the ARDS literature, the acute respiratory distress syndrome literature, which again, we're just doing so many shout outs now, I suppose, but we also have that playlist on ARDS. We're just going to click on that too. Boom, I won't click on any of the videos though. And one of those is management strategies, where we talk all about different management. But steroids for biotrauma, extrapolated from the ARDS literature, may be effective in treating that. There's also this confusing concept of ergotrauma, and we're not going to spend much time on this, but this is the idea that on prolonged high mechanical power, so you're on a ventilator and your body's experiencing a certain amount of mechanical power from that ventilator, complex topic. Even if you have optimal distension of the alveoli, you still can have ergotrauma over time just from your lung tissue absorbing all that mechanical power from the ventilator. And getting someone off the ventilator as quick as you can is the best thing to prevent this, but also optimizing driving pressure and respiratory rate, two concepts that are probably a little complex. Respiratory rate is obvious, that's how many breaths you get per minute. And the more time you're having the ventilator give a patient a breath, the more exposure they're having to the ventilator's mechanical power. And then driving pressure is related to optimal alveolar distension. We're probably not going to dive too deep into it in this lecture, but just know that it also contributes to mechanical power. So we talked about now for underdistension, atelectrauma, which is that repeated opening and closing of an underdistended alveolus that leads to injury of that, but also injury to neighboring alveoli and small airway. And what you want to do is you want to try to optimize the PEEP best you can to have this underdistended alveolus become optimally distended. But then we talked about how even with optimally distended alveoli, you can still get biotrauma, that inflammatory response in the lungs that causes direct damage to the alveoli. And that's usually worse when the lungs are under more stress. So if you have other types of ventilator-induced lung injury going on, it can increase the amount of biotrauma. But even if you have an optimal distension, you still can get biotrauma. We then talked about ergotrauma, which is when just that lung is exposed to prolonged periods of mechanical power from that ventilator. And respiratory rate, higher ones for prolonged periods of time can lead to this, because every time you get a breath, it is the mechanical power from the ventilators being experienced by the lung tissue. Now we're going to talk about overdistension. This is when the alveoli is too, quote-unquote, inflated. Just like a balloon is overinflated, this is overdistended. And this can lead to two associated things, barotrauma and volutrauma. And barotrauma is baro and trauma, high pressures. If this overdistended alveoli, if the alveolar tissue is experiencing high pressures, it can cause barotrauma because that causes stress on that alveolar wall. And that's why we often target, again, extrapolated from the ARDS literature, a plateau pressure less than 30 and a driving pressure less than 15. And these two concepts are concepts we talk about in other videos in our mechanical ventilator series. You also get exposed to volutrauma when you're overdistended, and that is just that alveolus is getting too much volume. Every breath a patient is getting is pumping in too much volume that is overdistending that alveolus. And that's why we often try to target, when you're on a ventilator, lower tidal volumes, less than 6 cc's per kg of ideal body weight, to limit the amount of volutrauma that patient is experiencing. And these are the primary types of ventilator-induced lung injury, as well as their kind of simplified management strategies. So what to know here is that ventilator-induced lung injury does occur, and there's ways we can try to minimize it with the strategies we talked about. And if we use those strategies, hopefully we can bridge people, get them the treatments they need, and then get them off the ventilator as quickly as possible, because we never like to leave anyone on a ventilator longer than their lungs are absolutely demanding. These are two separate pressures that the ventilator measures. And the reason they're separate is because they represent different physiologic findings, right? The measurement they are taking represents two distinctly separate things. The nice thing about peak and plateau pressures is it can give us a clue into the patient's physiology. In addition to that, we need to manage these pressures. We don't want them to go too high because they can, like barotrauma, where the lung gets too distended, the alveoli get too distended, and as such they get damage. But to further understand some of these concepts, it really is helpful to dive into what these pressures are representing. So if we scroll down, we drew a quick and dirty version of the lungs, right? Right side, left side. This is the trachea, the main stem bronchi, and all these bronchi obviously break up into smaller and smaller, bronchi into bronchioles, and eventually, if you were to zoom way in, this would end in kind of these balloon-shaped alveoli, right? And these are kind of balloon-shaped alveoli. That's a really terrible drawing. Let's try it again. Terminal alveoli, and these are the little balloons that actually inflate and deflate for gas exchange. This blue thing here is an endotracheal tube, right? There's a plastic tube that goes into the trachea. You blow up a balloon here so it forms a seal, right? And the ventilator delivers a breath into the endotracheal tube, right? That breath comes out of the end into the trachea. It goes into both bronchi, and then it waves its way into all the bronchi and bronchioles into the alveoli, and then it inflates the alveoli and expands the lung, right? So this lung expands out. After the breath is stopped on the ventilator, right, the lung then contracts back in, and the air goes the opposite way. So it travels back out the main stem bronchi into the trachea, into the endotracheal tube, and then out the endotracheal tube towards the ventilator. Right? That's just the basics of how a breath is delivered on mechanical ventilation. So when we're evaluating a patient on the ventilator, let's just say you're prepping for rounds in the morning to present the patient to the attending intensivist, there's two pressures that we're interested in, right? The first is the peak pressure, and the second is the plateau pressure. And these are both pressures that you can get off the ventilator. The peak pressure is often in the top right corner. It depends on the ventilator brand, but the top right corner. And it's a pressure that you get with every single breath. Whereas the plateau pressure is something you actually have to test for. You have to do this inspiratory hold maneuver that we'll talk more about to get the plateau pressure. So what are these? Starting with the peak pressure is the pressure the ventilator is experiencing when it tries to push a breath into the lungs. So ponder that for a second, right? This is a closed circuit, right? This endotracheal tube ends up coming out of the patient's mouth, and then there's kind of tubing that weaves away onto the ventilator itself. But this is a closed circuit. It's not open to the external environment, right? From the tubing to the endotracheal tube, there's this balloon that causes a seal into the lungs. So when this ventilator delivers a breath, the breath travels through the tubing, through the endotracheal tube, through the bronchi, and into the lung tissue. And the pressure that is required to flow that breath through the tubing, the endotracheal tube, these airways, and inflate the lung is the peak pressure. And that's why you get it with every single breath. Because when the ventilator pushes that breath in, it says, oh, this is the peak pressure that I experienced while I was trying to inflate the lungs on that breath. So if we think about what that means is it's really a manifestation of the airway resistance and the alveolar resistance, because those are the two things that are happening. The breath is traveling through the airways, and then it's inflating the alveoli. So the resistance of those airways and the resistance of those alveoli are what is going to create the pressure that ventilator experiences while it's trying to deliver a breath. Right? If we just make this more simplistic, let's just picture you had a pump, right? Here's your pump. It's got a little nozzle at the end, and that nozzle is kind of plugged in to a pipe, right? And then there's a balloon on the end of that pipe. The peak pressure would be the pressure it takes you to pump a breath through this pipe into the balloon and then start to inflate the balloon. Right? If you're blowing into that, the amount of force you have to push in, the pressure required to flow the air through that pipe and inflate the balloon is the peak pressure. And that is why it's a manifestation of the resistance of those airways to the breath flowing through them, as well as the alveoli resistance as they try to inflate. So really the peak pressure is airway and alveoli resistance, okay? Now, as we talked about, it's detected when the breath is being delivered, right? Because it's an airway resistance. As the breath is flowing through these airways, that is when it detects the peak pressure. And do note that this is all in volume control. This is more of kind of an advanced topic and probably outside the scope of this video. But there's different modes of mechanical ventilation. There's volume control, there's pressure control, there's SIMV, there's APRV. There's all these different types of mechanical ventilation where you can deliver breaths differently. And peak pressure is really a discussion in this context for volume control, which is the most common modality of mechanical ventilation. Okay, and the acceptable norm, I put acceptable in quotes here because acceptable is not necessarily normal. Acceptable is what we tolerate without getting very concerned and having to adjust the ventilator settings. And the acceptable peak pressure is less than 40 centimeters of water. So when you look at the ventilator and you get this reading, the peak pressure, you're going to get a reading that says X centimeters of water, right? Maybe it says 33 on that breath, 32 on the next breath, 34 on that breath. And these are all pressure measurements, right, in centimeters of water. This is in contrast to the plateau pressure. The plateau pressure is detected with what we call an inspiratory hold maneuver. So essentially what we're doing is we are pushing a breath in, and then we are pausing the ventilator. We're not letting any air out of the ventilator, and we're not letting any more air go back into the lungs. So I'm going to erase all this and we can see if we can kind of draw it. I'm going to redraw, right? The endotracheal tube comes out the mouth. There's this tubing, right out the mouth. There's this tubing, and it goes onto the ventilator. And again, this is a closed circuit. The idea that it's a closed circuit is really important. So when we deliver a breath in, as we said, the breath travels through the tubing, through the endotracheal tube, through the trachea, the bronchi, into the bronchioles, and then it inflates the lungs, right? It goes to both sides, obviously. The plateau pressure is the pressure experienced when this breath is pushed in, but not let back out. And you pause the flow on the ventilator. There's no air flowing in or out, right? So just picture it. It's essentially if you took your own breath in, and then you just held it in your lungs. You're not letting any air in, you're not letting any air out. But you can almost feel the pressure in your chest when you do that, right? Because your lungs are inflated, and your lungs are tissue. So as the air is pushing those lungs out, the lungs are also pushing back in. They're trying to deflate back down. And if you're not letting any of that air escape, the plateau pressure is the pressure that the vent is feeling as those lungs try to deflate when we won't let them. It's an inspiratory hold. So as one might assume then, that plateau pressure is more representative of the lung compliance. The compliance being how easy those airways are to kind of distend out and collapse back in. You can also think of it as kind of an alveolar resistance and lung compliance measurement. So if we think about what this is saying, the plateau pressure is actually sort of a part of the peak pressure, right? Because as we said, the peak pressure is when we push an air in, and part of the peak pressure is airway resistance, but the other part of the peak pressure is we have to inflate those lungs, right? And if we're saying plateau pressure is lung compliance, the force that the lungs are trying to push back in on that breath, you can think of the peak pressure as airway resistance plus lung compliance plus the plateau pressure. The physiology there isn't perfect, but it's somewhat helpful in understanding these two things. Because when we think about peak and plateau pressure, we're going to talk about kind of highs and normals. An acceptable plateau pressure is less than 30, right? And that's acceptable again, because that's not necessarily normal. If you put a healthy person on a ventilator, their peak and plateau pressure would be very low, right? So this is acceptable. This is what we think is okay and will not induce a significant amount of barotrauma or overinflation or overdistension of those alveoli. So the difference between these two, the peak and plateau pressure, is important. Because if they are the same, right? If the peak equals the plateau pressure. Let's say the peak pressure is about 30, and then you do this inspiratory hold, and the plateau pressure on the inspiratory hold is also 30. That is really saying that most of the pressure that you're seeing in the peak pressure is simply lung compliance, and that there's not much airway resistance, because lung compliance and airway resistance make up the peak pressure. Right? Does that make sense? So if the peak pressure is proportional to airway resistance, right, we'll just say airway R, and lung compliance, lung C, and we're saying the plateau pressure is proportional to lung compliance. If the peak equals the plat, that just means that all the peak pressure is lung compliance and the airway resistance is not contributing. That's in contrast to if the peak pressure is greater than the plateau pressure. So let's just say the peak pressure is 50 and the plateau pressure is 20. Well, now this changes, right? Because if we're saying the plateau pressure is 20 and the peak is 50, we can essentially say that, well, 20 is related to lung compliance, but the other 30 left is airway resistance. And this can be helpful when understanding the pathophysiology going on, because these two represent different things. So anytime the peak pressure is high, the second question is, what's the plateau pressure? And if the plateau pressure equals the peak pressure, this is really a lung compliance problem. If the peak pressure is greater than the plateau pressure, it's really an airway resistance problem. And both could be high, and it could be a both problem as well, but the differentiation between the two is important in deciding if it's an airway resistance problem or a lung compliance problem. Because airway resistance and lung compliance are going to represent different things, right? So as we mentioned, let's say there's a high peak pressure and a high plateau pressure, right? So peak pressure is 30, let's make it 50, plateau pressure is 50, that's very high. Well, remember what we said. If the peak and plateau equal each other, this is really just a lung compliance problem. Because the plateau pressure is lung compliance. And if the plateau equals the peak, that means airway resistance is not playing a big role, because we said peak pressure is airway resistance and lung compliance. So if they equal one another and plateau pressure is just lung compliance, again, means airway resistance isn't playing a role. So then we think about the things that cause an abnormal lung compliance. And that is the pathophysiology that's leading to that high peak and high plateau pressure, abnormalities in lung compliance. And those abnormalities, easy way to think about it is kind of blood, water, pus, inflammation, fibrosis, right? Blood being things like hemoptysis. If you have blood within the lung parenchyma itself, hemoptysis isn't the disease, but it can be caused by a number of things, right? DAH. It can be from any type of arterial bleeding in the lung, right? So blood in the lung can cause abnormal lung compliance, right? Because that blood gets in all those alveoli, clogs them up, doesn't allow them to distend as they would normally, right? Water, so things like pulmonary edema, P edema, can cause an abnormal lung compliance. Pus being infection, so things like pneumonia. All right, inflammation can be from anything. Let's say you have pneumonitis from, maybe you aspirate and you have aspiration pneumonitis. Maybe you're on a, some type of chemotherapy agent that causes medication-induced pneumonitis. So any inflammation in the lung. And then fibrosis, right? Fibrosis can cause the lungs to have decreased lung compliance. Maybe it's like interstitial lung disease causing fibrosis. So if you remember these, that gets you through most of the things that can cause an abnormal lung compliance. The other thing is if you're not ventilating all the lung like you think you are, right? So if you intubate someone and you accidentally main stem them, right? Meaning the endotracheal tube is actually going into just one of the main stems. That means you're not really ventilating this lung. So you're trying to push all the tidal volume into a single lung, and that will lead to a high plateau pressure because that lung is exerting that much more downward pressure as it is trying to accept that full tidal volume. Similarly, if you had lung collapse of a certain area of lung, that would cause higher plateau pressure as well because you're ventilating less lung than you think you are. Or if you haven't had a pneumothorax, a popped lung, let's say this lung's totally collapsed because there's a pneumothorax. Again, you're just ventilating one lung. And the amount of tidal volume is the amount of tidal volume, right? Let's say you set the tidal volume at 500. That tidal volume is supposed to go into both of the lungs, right? And if it's only going into one of the lungs, so instead of getting 250 and 250, this lung's got a pneumothorax and is collapsed down. That means now you're trying to put 500 cc's of tidal volume in that one lung, and you're going to over-distend it. You can think of it like a balloon again, right? If you're pushing 250 cc's into a balloon and then you try to push 500, that pressure, that compliance that it's coming back down with is going to be more robust. Okay? So if you're not ventilating both lungs the way you think you are, whether you main stem the intubation or have a pneumothorax or have some degree of collapse, then otherwise this blood, water, pus, inflammation, fibrosis are the things that can cause abnormal lung compliance, which is the high peak and high plateau pressure. And this is just to echo, right? Because the peak pressure of some of the ventilator just tells you on each breath. So if that peak pressure is high, the second question is always, what's the plateau pressure? So do that inspiratory hold. It's a button on a ventilator. You hold the button and it pushes a breath in and then it holds it and it tells you what the plateau pressure is. Because the plateau pressure equals the peak pressure, then you know it's a lung compliance problem. Whereas if the plateau pressure is normal, it's low, so it does not equal the peak pressure, cue this other one, we know it's an airway resistance problem. I feel like I'm repeating myself over and over, but this is just to really drive home the point, right? Peak pressure is both airway resistance and lung compliance. Because the peak pressure is the pressure the ventilator is experiencing when it's pushing a breath in through the airways and inflating the lungs. Whereas the plateau pressure is just a lung compliance problem because the plateau pressure is when the ventilator pushes a breath in and then holds it, doesn't let any gas flow back and forth. right? And then that is just a representation of the lung compliance. So if it's a high peak pressure to normal plateau pressure, you already know the lung compliance is normal, right? So you're taking this out of the peak pressure equation, so you know all that's left is airway resistance, so you have an airway resistance problem. And anytime you have an airway resistance problem, what you want to do is you want to trace the circuit, I call it. Because remember what we said. We said you have a ventilator, and you have ventilator tubing. And that tubing then attaches to the endotracheal tube, right? And that endotracheal tube is going into the lungs, into the trachea. The endotracheal tube's got a balloon here and a balloon here, and it is creating a closed circuit for your lungs. So if you have airway resistance, that does not just mean airway. That could be resistance in the endotracheal tube. It could be resistance in the tubing. So the first thing you always think about is endotracheal tube pathology. Is there a kink in the tubing? Is the patient biting the tubing, making it more smaller, making it more small? Is the endotracheal tube too small to start with? Is there mucus built up, right? Because all those things are going to increase airway resistance. I'm just going to draw an endotracheal tube, right? If you're trying to flow air through this endotracheal tube, and let's say there's mucus built up on the side, you got a big Goomba right there. Now that air's trying to flow by a smaller area, and that's going to lead to more resistance. Or let's say the patient's kind of biting down on the endotracheal tube. So instead of this nice flat surface, you have this huge kink in the side because the patient's biting down on it. Again, you're going to have to try to flow that air past a smaller surface, and that's going to cause higher airway resistance, a higher peak pressure. So the first thing to do is to trace the circuit, trace the endotracheal tube. If the circuit and the endotracheal tube are all okay, well then you actually are having a true airway problem. And just like the endotracheal tube pathology, the problem with the airways could be mucus plugging, right? You could have mucus built up in one of the airways, just like you could in the endotracheal tube. Now you're trying to push air past mucus built up in the airway, smaller area to push it through, higher airway resistance. You also could have bronchospasming of the airways itself. Maybe the patient has COPD or they have asthma, right? And those bronchospasms is when those bronchi kind of spasm down, right? Creates smaller amount of area to flow that air through, higher airway resistance. Maybe there's a foreign body in the area. Maybe the patient has ventilator desynchrony. They're not being cooperative with that breath, and they're kind of pushing back on it. All those things can cause high airway resistance. So again, high peak pressure. Second question is, what is their plateau? If it's a normal plateau pressure, then you know the lung compliance is normal and you have an airway resistance problem. If it's a high peak pressure and a high plateau pressure, then you know it's a lung compliance problem and not an airway resistance problem, right? And that similarity between the two is if they're within about 5 centimeters of water. Now, if they are both high, right, let's say the peak pressure is 60 and the plateau pressure is 40, they're still different enough where you have an airway resistance problem, but you also have a lung compliance problem because they're both high, right? We said acceptable plateau pressure is less than 30, and we said an acceptable peak pressure is less than 40. So they're both high, but the peak is higher than the plateau. So we know that you have both a lung compliance problem and an airway resistance problem. All right, so if you think about it that way, it sticks a little bit better, I think. And then last but not least is just the scalars. If you don't have an interest in this or don't have the background, this certainly isn't that important. But this is a pressure versus time scalar. This is something that shows up on the front of the ventilator screen. And remember, this is in volume control. And you can see here that this is 0 for the pressure. The peak pressure is going to be the peak pressure that the ventilator experiences when it's pushing a breath in, right? So this is where it's starting to push a breath in, and then it gets to this peak. And this is what the ventilator is putting on the side of it, right? This is 30, the peak pressure is 30. The plateau pressure, though, as we said, is a maneuver you have to do. So I wonder if I take a marker, I'm just going to draw over this so we can draw something fresh. Just pretend like it's the same color as the other ones. So if you do an inspiratory hold, right, a patient takes a breath, they have the peak pressure, and then you have an inspiratory hold, the ventilator will go like this. This is when it's holding the breath. And then you let go, goes back down to 0, and the patient can take their normal breath again, okay? This here is the plateau pressure, right, this portion of the inspiratory hold. So that is literally on the scalar will give you a pressure. You know, if this is 30, let's say maybe this is just 20. Nice normal plateau pressure. And it will kick this out on the screen too. There will be a little area that says plat, and then it'll give you a number like 20. But you have to do the inspiratory hold, right? You have to hit the button. and our respiratory therapist will do this. Certainly shouldn't be doing it too much on the ventilator without the respiratory therapist, especially if you're early on in your training. But you have to do an inspiratory hold to get the plateau pressure, whereas the peak pressure is just that peak pressure at the end of each breath, and that's an automatic thing the ventilator reads. So hopefully that was helpful or interesting, or at least stimulated some additional reading. Let us know what thoughts, comments, questions you have down below. Definitely check out our Patreon page, our other related videos, and certainly we appreciate you checking it out. In any case, stay well, keep learning. We'll see you next time.
All right, everybody. Welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody is doing well. Today's topic is one that a lot of people have kind of requested or brought up questions on. And it's a Mechanical Ventilation Advanced series, specifically talking about driving pressure. Per usual, quick disclaimer, this is never intended to be medical advice. Please stick around to the end of the episode or check out the episode description for the full disclaimer. And then a couple shameless plugs. We have a Patreon page. We upload the study guides to the videos, practice questions, public health, emerging infectious disease, all that good stuff. We have a weekly newsletter that focuses more on public health and emerging infectious disease. And obviously we have a YouTube page, podcast platforms, all that kind of stuff. We would love for you to check out some stuff. All of it's linked in the episode description. So dive in. We'd love to have you. Enough of the shameless plugs. Let's dive into driving pressure. What is driving pressure? Well, driving pressure is a variable that we can determine when someone's on mechanical ventilation, okay? It represents the pressure difference needed to inflate the alveoli during each breath. And we're going to come back to that as a concept, okay? So it kind of represents this interaction between tidal volume and compliance of the respiratory system. And it's really emerged as a marker for lung stress and possible risk for ventilator-induced lung injury. If we were to kind of try to bring it down to a lower level, it's kind of the amount of pressure the ventilator uses to quote-unquote open the lungs beyond their resting state. And this definition will make more sense, I think, when we start to talk about the equation for it. We'll loop back around to it. It depends on how your brain works, but sometimes understanding the equation, how to calculate it, then helps us better understand the concept behind it. So, good transition. How to calculate driving pressure. So there's two main formulas depending on the data you have. One of these is the most common. So we're going to start with the less common formula. And the less common formula, if you know the compliance, is that driving pressure is actually the tidal volume divided by compliance. And this is a representation of what driving pressure is, but is not as clinically useful. The more clinically useful equation, which is the one that most people use, is that driving pressure is the plateau pressure minus the PEEP. And this equation is best applied to a patient who is passive, so they don't have a lot of ventilator desynchrony or interaction with the ventilator, and they're on volume control. So they can't be spontaneously breathing, they can't be desynchronous. This has to be a patient on volume control who's fairly passive. They're not interacting much with the ventilator. And what you have to do is you have to get a plateau pressure. If you do not know what a plateau pressure is, this video is probably a little beyond where you're at. We have a whole playlist on all things mechanical ventilation where we dive into plateau pressure. It's linked in this episode's description, so definitely check that out and then return to this. For those of you who do know what a plateau pressure is, friendly little reminder, you have to get a plateau pressure with an inspiratory hold. And this you kind of set on the ventilator, right? You click a little button and do an inspiratory hold, and this essentially means there's no flow of air going through the airways. You pump a breath in and then you just hold, and you check the pressure. And this is more representative of things like lung compliance or alveolar compliance. And the driving pressure then is the plateau pressure minus the PEEP being the positive end-expiratory pressure. And if we really think about this, what we're saying is I'm going to push a breath in and hold it, which is going to help me just see kind of alveolar pressures, lung compliance. And I'm going to subtract the PEEP from that. And it's going to give me a number. And the lower the number, the better. Which essentially means the higher the PEEP and the lower the plateau pressure, the better. Whereas if the plateau pressure is going up more than the PEEP is going up, the driving pressure will be higher, and that is worse. And we're going to circle back around to this, but I want you to kind of picture that. And maybe we'll do it now and we'll talk about it again in a second. So when we think about the plateau pressure and we think about the PEEP, lower driving pressure is better. So the plateau pressure minus the PEEP, we essentially are saying that you have this alveoli, and this alveoli is experiencing the PEEP that we set, the positive end-expiratory pressure, right? This is the pressure that's there all the time, both inspiratory and expiratory. And if we set that PEEP at 5, that is going to cause the alveolus to be distended to a certain amount. And then we check a plateau pressure. And if that alveolus is perfectly distended, that plateau pressure, that inspiratory hold, that pressure that's reflective of alveolar distension, is going to be probably low. And we're going to have a low plateau pressure, and the driving pressure then is going to be lower. Whereas if we have an alveolus that is over distended because there's too much PEEP, the PEEP's at 15, that plateau pressure is going to be really high. And if we play around with this in our brains, let's say that we have a plateau pressure. Let's say the plateau pressure is 20 and the PEEP is 5, okay? And that's a driving pressure of 15. And we're like, oh, well, actually, let's change this. Let's say the plateau pressure is 30 and the PEEP is 10. That is a driving pressure of 20, right? Driving pressure is plateau pressure minus PEEP, 30 minus 10, driving pressure of 20, okay? And we're going to draw an alveolus if you're watching the YouTube video, and that alveolus is here, okay? And let's say we're like, goodness, is this the right amount of PEEP? Could they be under distended, under recruited, or over distended, over recruited? And I think, based on my clinical assessment, that they are under distended, right? I think this alveolus is kind of collapsed down and they're under distended. So what I'm saying is, I think if I go up on the PEEP, that will cause the alveolus to be perfectly distended, which means that the plateau pressure won't really change, because I'm just going from kind of an underdistended, shriveled down alveolus to a normally distended alveolus. So what this would look like is I increase the PEEP from 10 to 14, and I let that PEEP take hold, and then I check another plateau pressure. And that plateau pressure maybe is 30 again. And now what I'm saying is, okay, my driving pressure is 30 minus 14, because that's my new PEEP, and that is a, 30 minus 14, yeah, because that's my new PEEP, and that is a driving pressure of 16. Whereas at a PEEP of 10, that driving pressure was 20. So I went from a driving pressure of 20 down to 16, which then tells me that that PEEP change was good. Changing that PEEP from 10 to 14 just helped recruit more alveoli, that before they were under distended, because the plateau pressure didn't really go up much, even with an increase in PEEP, which made that driving pressure go down. But if we take the other scenario, right, we're going back to they're at a plateau pressure 30 and a PEEP of 10. And I think I'm like, oh, I think they're under distended. So I increase that PEEP to 14, like I did. So the PEEP goes up again, 10 to 14. But I was wrong. They were not under distended. So now this alveolus is super over distended at that PEEP of 14, and I check a plateau pressure. And that plateau pressure is probably, 36 now. So if I do a driving pressure now, 36 minus 14, that driving pressure is now 22. It got worse. It went up. And that tells me that that PEEP change is just over distending alveoli. It's causing more barotrauma. It was the wrong thing to do, if that makes sense. We'll come back to it. All right. So what does it mean clinically? What does the driving pressure mean clinically? Well, as we mentioned, lower driving pressures suggest that less force is being used to inflate the lungs. And this often indicates the lungs are at a better compliance, more optimal compliance, whereas higher driving pressures mean that there's more force needed to inflate the lungs, and the lungs have kind of a lower compliance, aka stiff lungs or over distended lungs. So lower driving pressures are quote-unquote good. Higher driving pressures are quote-unquote bad. And driving pressure is a surrogate for what's considered kind of lung stress, strain, associated ventilator-induced lung injury. So that higher driving pressure can suggest that those lungs are sustaining ventilator-induced lung injury, and we got to make some changes. So when we use driving pressure, the things to think about are lung compliance. And there's two different ways to think about this. Actually, three different ways. One way is following the driving pressure to better understand how lung compliance is changing. So if you are not changing the PEEP, but the driving pressure is getting worse or getting better, it suggests the lungs are getting more or less compliant. So again, just scenario, the plateau pressure is 20, the PEEP is 5. Your driving pressure is 15, right? Driving pressure is 15 because it's your plateau minus your PEEP. And you haven't made any adjustments, but you check a driving pressure the next day, and the driving pressure the next day is 22. That's probably too robust of a change, but you get the point. What you're essentially saying now is the compliance has changed. Something's going on. Maybe the patient is developing worsening ARDS. Maybe they're having progression of illness because the driving pressure has gone up even though you haven't changed the PEEP. That suggests that the plateau pressure is going up. Same thing in the opposite direction, right? Let's say your plateau pressure is 30 and you're at a PEEP of 10. And for whatever reason, that's the best you could do. Your driving pressure was 20. You don't make any changes, but you check the next day and the driving pressure is down to 15. That essentially means that plateau pressure is getting better and the compliance is getting better. Whatever illness was going on is improving. Okay, so if you're not making adjustments, honestly, you can track the plateau pressure too. But a lot of times things are a little more complex, and driving pressure can be a helpful surrogate, but it can be an indication of how the lungs are evolving from a compliance standpoint, either worse or better. Okay, so assessing lung compliance. You can also use it to titrate ventilator settings, and I think that's what a lot of us do now, especially in ARDS. You can try to find an optimal tidal volume and PEEP to achieve the lowest driving pressure. And that's kind of what we were talking about, right? You can do PEEP titrations while checking driving pressure intermittently to see if the patient is, if their alveoli are optimally distended. And there's fancy things like stress index, which can help you understand this. But essentially, you're trying to get the alveoli to the most optimal amount of distension by titrating their PEEP, either up or down, right? If you think they're over distended, you want to titrate the PEEP down. If you think they're under distended, you want to titrate it up. But the driving pressure will help you understand if you made the right decision. Because if that driving pressure goes down, that means your PEEP titration was good. If your driving pressure goes up, that means your PEEP titration was wrong, and you should think about going in the other direction, whether it be up or down. And then predicting outcomes, we don't use this as much, at least personally, but elevated driving pressures are associated with increased mortality in mechanically ventilated patients. So if you were to think a little bit about the evidence, this is just as of this video recording, there's certainly other evidence out there, but in 2015 New England Journal of Medicine, there was a landmark meta-analysis of patients with ARDS, and this is when driving pressure kind of came more so into the forefront. And it found that driving pressure was more strongly associated with mortality than even tidal volumes or PEEPs. So it suggests that reducing the driving pressure may improve survival in these patients with ARDS. There's been subsequent studies that kind of support this concept that you should be targeting a lower driving pressure, not just tidal volume or PEEP. But most of these are associative studies. There hasn't been, at least as far as we're aware, these robust RCTs, although they probably will be coming, so stay tuned. When we think about important clinical considerations and caveats, again, this is really only valid during passive ventilation. If the patient is breathing a lot on their own, they're desynchronous, what have you, you can't really do this. It confounds the measurements. You need a plateau pressure to do this. So you have to measure the plateau pressure appropriately or your driving pressure will be off. And just remember, this is affected by chest wall compliance. Although the driving pressure takes some of that out of the equation, it still does take it into account a little bit. So clinical takeaways here and then key summary points. Driving pressure is a powerful, easy to calculate variable that does reflect lung compliance and injury risk, especially in ARDS, and targeting that driving pressure of less than 15, that's your magic number, less than 15 is what the evidence would suggest may be correlated with more improved outcomes. Okay, key summary points, I think we're there. Driving pressure formula is plateau pressure minus PEEP. You want it to be less than 15. Higher driving pressure implies poor lung compliance and increased ventilator-induced lung injury risk. Best use in ARDS management. And remember, the patient has to be passive, or you cannot get an accurate measurement of this.
And no further ado, spontaneous breathing trials. So what are spontaneous breathing trials? Well, a spontaneous breathing trial, as many of us know, is kind of the gold standard bedside assessment tool to determine whether a patient can safely be liberated from mechanical ventilation, right? So it's an evaluation on the patient's ability to breathe without significant ventilatory support, right? A way to simulate extubated conditions as a way to know or understand if a patient might be ready to be liberated from mechanical ventilation. So the goal here is we're trying to identify the readiness for extubation. A really important thing. Obviously, you don't want to leave anybody on the ventilator longer than you have to. There's certainly complications that can come with being on mechanical ventilation, ranging from just ventilator-associated lung injury to ventilator-associated pneumonia, sedation, delirium, all that stuff. So getting patients liberated from mechanical ventilation is critically important, one of kind of the cornerstones of critical care medicine. So the goal is to identify who's ready to come off the vent. Timing for spontaneous breathing trials, in general, and we'll dive more into the details on this, but in general, we're usually doing this after improvement in the underlying illness, right? What caused them to be intubated? And have we improved that enough to no longer need the ventilator, right? If the cause was that they were completely obtunded and unresponsive, are they awake now? If the cause was they had profound hypoxemia from pneumonia, is their pneumonia improving, right? All these things make sense. So have we addressed the underlying cause in a way in which we think they might not need mechanical ventilation anymore? Hemodynamic stability is another one. There's lots of gray to hemodynamic stability. The old adage used to be that you need to be totally stable, off vasopressors, the whole gambit. Now we're starting to understand that, you probably don't have to be totally off vasopressors. How much vasopressors are reasonable to come off the vent? Still an unanswered question. But some degree of hemodynamic stability, or maybe the more appropriate way to contextualize it, would be hemodynamic improvement. If you were on 30 micrograms per minute of norepinephrine and vasopressin, and that vasopressin's now off and your norepinephrine's down to, 5 or 8 micrograms per minute, maybe that's a patient who, even though they're still on vasopressors, you could consider liberating from the ventilator. This is not medical advice, never is. You should certainly verify all this before acting on it. We have disclaimers in the episode description and at the end of the episode, but anecdotally, our practice pattern, we're okay liberating patients from mechanical ventilation who are still on vasopressors, assuming we're improving their underlying illness. And then the last thing is adequate oxygenation and ventilation, obviously. So, I think many people, and we'll go into this more, many people would put a PEEP of less than 10 and an FiO2 of less than 60% as kind of two oxygenation goals before you can put someone on a spontaneous breathing trial. Some people are more particular, right? Some people talk about a PEEP of less than 8 and FiO2 of 40%. Some people maybe are a little more aggressive. Anecdotally, again, we use this PEEP less than 10, FiO2 less than 60% personally. And then typical duration of these spontaneous breathing trials, 30 to 120 minutes is probably reasonable. Some of the trials used 30 minutes before they extubated patients. Other people use a little bit of longer time frames. So 30 to 120 minutes, again, lots of gray here, which is good. That's why we're doing this video, so you can kind of hear a little bit of insight and practice patterns on that. So how do we actually do the spontaneous breathing trial? Well, it'd be easy if there's just one way to do it, but there's not. So the first thing when you're talking about it is, do they meet some of those prerequisites we mentioned, right? FiO2 less than 60%, PEEP less than 10, depending on who you are. Might vary per patient, but are they oxygenating well enough without significant ventilator support? Are they ventilating, right? Are they not hypercapnic? Do they not have acute hypercapnia where they're able to ventilate well enough on their own? Do they have some degree of hemodynamic stability or hemodynamic improvement? Do they have an adequate mental status? Can they protect their airway? If you were to extubate them, are they able to protect their airway? Do they have a cough? Are they awake enough to spontaneously ventilate on their own? Are they strong enough to do that? These are some of the soft indicators that someone is ready to come off the vent, potentially. And then the last thing is secretions, or can they manage their own secretions? And this is tough because a lot of times we're like, oh, they have significant secretions. What do you do with that? Gosh, we don't know what to do with that. You know, if they have a strong cough, hopefully they can mobilize those secretions on their own. If they have a weak cough and lots of secretions, maybe that's someone you give a little more time on the vent. Tough to say, but secretions is something that you should at least evaluate for and think about before you liberate someone from mechanical ventilation. And then the other thing, like anticipated procedures, are they going to the operating room in 5 hours? If so, maybe you leave them on the ventilator. Do they need a MRI of their brain and a whole spine in 2 hours? You know, that's a long test. Maybe leave them on the ventilator. So just kind of anticipated clinical course is another thing to think about. So if you've decided that, yes, they meet the prerequisites, and yes, you want to do a spontaneous breathing trial, well, what the heck do you do then? What are the different methods to do a spontaneous breathing trial? We're going to talk about the two less common methods, and then we'll talk about the more common mainstream method. The two less common methods are a T-piece trial and a CPAP trial. And I want to be very specific with the verbiage here, because at times people call a pressure support trial a CPAP trial, and that's not necessarily true, and we'll get into that more. But starting with the T-piece trial, this used to be much more mainstream. We personally don't really do T-piece trials. We've maybe done it once or twice for kind of weird, unique situations. But in general, we don't do T-piece trials. And what a T-piece trial is you literally take someone off of the ventilator and you let them breathe through their endotracheal tube just hooked up to supplemental oxygen. There's no ventilator assistance at all. There's no PEEP. There's no inspiratory pressure. There's nothing. They're breathing through the endotracheal tube hooked up to wall oxygen. And there's some trial data to suggest that this isn't necessarily the best modality to use for a spontaneous breathing trial. In fact, outcomes were worse. And again, we'll talk about that trial in a second. But it makes sense that outcomes might be worse, right? Because you essentially have a straw, aka the endotracheal tube, going into someone's airway, and you're taking away all support and just having that patient try to breathe through that straw. So they don't have any PEEP, which means they can get alveolar collapse and atelectasis. Right? You don't have any inspiratory pressure. That inspiratory pressure, the pressure that is delivered during a breath, kind of gets over the resistance of the endotracheal tube. Try just breathing through a straw. That's hard, right? Now imagine being on a ventilator, being taken off that ventilator and being asked to breathe through that straw. So T-piece trials are not mainstream anymore, and for good reason, which we'll talk about. The other one we wanted to talk about that isn't commonly used is an actual CPAP trial. And we sometimes call pressure support trials CPAP trials, but an actual CPAP trial is that you just leave the patient on PEEP, but you take away all inspiratory pressure. So what this means is, the patient's still on a PEEP of 5, but otherwise they're just breathing through the endotracheal tube themselves. There's no inspiratory assistance. So you still run into the resistance of that endotracheal tube, because every time the patient takes a breath, they have to suck air through that endotracheal tube without any assistance. There's still increased airway, there's still increased resistance trying to suck air through that endotracheal tube. And as a comparison to help that make sense, that gets into the more common approach to vent liberation and spontaneous breathing trials, which is a pressure support trial using pressure support ventilation. And what this is the most common way we do spontaneous breathing trials in the ICU, pressure support trials. And we essentially leave the ventilator providing a PEEP, just like it would for the CPAP trial, right? A positive end-expiratory pressure. And usually that's minimal. Usually that's 5. But again, some people talk about less than 10. Some people talk about less than 8. But 5 would be minimal. We leave a little bit of PEEP. And then we actually provide some pressure support, some inspiratory pressure support, anywhere in the realm of 5 to 8 above the PEEP. 5 being minimal, 8 being a little bit higher, but anything greater than 8 is a little more significant in terms of support, which I'll talk more about in a minute. But just to lay this out, so what happens is the patient's on the vent, you switch the mode of the ventilator to pressure support, and that ventilator does not deliver any breaths except when the patient triggers it. So if the patient doesn't take any breaths on their own, the vent doesn't give them any breaths. They're completely apneic until you eventually get to the apnea alarm, in which case the ventilator then has a backup mode that kicks in. But when the patient goes to take a breath, the ventilator senses that and it delivers a certain amount of inspiratory pressure, that pressure support, 5 millimeters of mercury, 7 millimeters of mercury, some type of inspiratory pressure. And the thought there is it's just enough inspiratory pressure to get over the resistance of the endotracheal tube. So it's not intended to provide actual inspiratory support. It's just intended to provide enough pressure to get past that resistance of the endotracheal tube. And then obviously you leave some PEEP on like we talked about. And that is the most common way we do spontaneous breathing trials, this pressure support trial. And as you can see then, the difference between the pressure support trial and a CPAP trial is the CPAP trial just has PEEP. It doesn't have any of that inspiratory support. And a TP's trial doesn't have PEEP or inspiratory support. You're just trying to suck air through that ET tube. So if we go into one of the trials that looked at pressure support trials versus TP's trials, it's a trial by Thill et al. 2016, published in JAMA, and it was a multi-center RCT, had about 1,000 patients in it. And they compared pressure support ventilation, where you have that inspiratory pressure and a PEEP, right? Just enough inspiratory pressure to get over the resistance of the endotracheal tube, somewhere around 5 to 8 centimeters of water, millimeters of mercury, and minimal PEEP, somewhere between 5 and 8, just to prevent atelectasis, versus a TP's trial. Remember we said TP's trial means you just take them off the ventilator and attach their ET tube to supplemental oxygen. And what they found in this was that pressure support trials were associated with lower extubation failure rates than the TP's trial, especially in high-risk patients, older folks, COPD, cardiac disease. And that's really interesting, right? Because it's saying that in patients you did the TP's trial on, you were more likely to have extubation failure. And you start to wonder, is that because you took away the PEEP and everything, and that patient got atelectasis and lobar collapse and all that jazz, and then you extubated them, and they had more trouble remaining extubated? Then the pressure support trial, where you have some inspiratory pressure and some PEEP still there to maintain recruitment, get over that endotracheal tube resistance. So from this trial, it supported the use of pressure support trials rather than TP's trials as the most physiologically relevant, patient-friendly SBT method, which is why not many people do TP's trials anymore. All right, so going into pressure support trials, since that's kind of the main way in which we try to do spontaneous breathing trials, this is the most common modern approach. And as we talked about, the endotracheal tube adds resistance when you try to breathe through it. So a small amount of inspiratory pressure helps overcome that resistance, which is actually more similar to kind of that normal physiologic airway after you extubate them, right? When you extubate them, you're not giving them a straw to breathe through, you're just letting them breathe normally. And a pressure support trial mimics that extubated state better. Typical settings, as we talked about, is an inspiratory pressure, also known as a pressure support, of 5 to 8, and a PEEP of, somewhere around 5, although some people would say less than 10, some people would say less than 8, and an FiO2 of less than 60%, although again, some people would say less than 50, or even 40 or less. So some variability in the PEEP and FiO2, but do note that this pressure support, this inspiratory pressure of 5 to 8 centimeters, if you start to increase that inspiratory pressure higher than that, you're no longer just overcoming the resistance of the endotracheal tube, you're actually providing them with significant inspiratory pressure support. And that's almost like pressure control. The pressure control mode of ventilation, where you're providing an inspiratory pressure to the patient to help them breathe. So you really want to make sure this pressure support is minimal. If you're starting to get a pressure support at 10 or 12 or 14, that is essentially pressure control. Obviously, you are still in a pressure support mode, but the amount of inspiratory pressure you're providing is significant. That is not mimicking, just enough inspiratory pressure to get over the resistance of the endotracheal tube. That's significant support. So this minimal pressure support number of 5 to 8 inspiratory pressure, 5 to 8 millimeters of mercury, is critical when you're doing these pressure support trials. All right, how to tell if a patient is doing well? Well, the first thing you should look at is the vital signs. Right? Have they gotten super tachycardic all of a sudden because they're an extremis, heart rate of 120, 140? Obviously, they're not doing well then. Have they gotten hypotensive or hypertensive? Also maybe an indication that they're having trouble. Now it's tough, right? Is it because of the wean and sedation? Is it because they're uncomfortable on the ventilator? All these things play a role. But vital sign derangements do imply that patients are much higher risk once you extubate them. Can they still oxygenate, right? Are they maintaining their SpO2 above 90? If you send a gas, a P to F ratio greater than 200, but really the message here is, are they still able to oxygenate while on a pressure support trial on the vent? Because if they're getting hypoxemic, that might indicate they're not ready to be liberated from the ventilator. Same thing with ventilation. Are they still able to ventilate adequately? They're not getting more hypercapnic. Some people routinely send gases when patients are on pressure support trials. We don't tend to do that unless we have something we're worried about. Sometimes we'll leave them on end-tidal and make sure there isn't some big jump in their end-tidal CO2 on the monitor. But obviously user preference on that one. but are they able to adequately oxygenate and ventilate? And then is their mental status still stable? Did you put them on pressure support and now all of a sudden they're obtunded and unresponsive, maybe because they're hypercapnic, right? Their mental status has to remain stable. And then do they have a tolerable work of breathing? They're not diaphoretic, they're not using accessory muscles, they're not belly breathing, they're not super tachypnic, right? Do they have a tolerable and stable work of breathing is the other critical thing. And this is all very subjective to a degree. You're looking at the patient, you're like, what do they look like? How are they breathing? Do they look comfortable, et cetera, et cetera. When we try to make this process more objective, one of the common markers people talk about is something called the Rapid Shallow Breathing Index, the RSBI. Some people call it the RSBI. And the Rapid Shallow Breathing Index is a math equation. It is the respiratory rate divided by the tidal volume in liters, okay? So respiratory rate divided by tidal volume in liters. And when people have studied this, if we think about what this means, it essentially means that they're breathing comfortably, so the respiratory rate is reasonably low, and that they're pulling high enough tidal volumes. Because you want the RSBI low. Less than 105 has been a good predictor of successful extubation. Now we'll go into the trial, one of the big trials on the RSBI, because it's not perfect, so you should always use it, with your clinical judgment. It's not an end-all be-all, but it's maybe an easy place to start, especially for trainees or people early in the field who kind of want something more graspable to help them understand if a patient can be liberated. The RSBI is a reasonable place to start, but it's not the end-all be-all by any means. Okay, so respiratory rate divided by tidal volume in liters. So one of the newer trials on this was from 2016. I don't know how to pronounce their name, apologies, but Tanios et al. Published in Critical Care Medicine. And it was a prospective multi-center observational study. Okay, so this is not a randomized control trial. And it looked at the rapid shallow breathing index in ICUs. And it was after there was this trial in 1991 by Yang and Tobin, which was kind of the OG RSBI trial, that showed a really good sensitivity and predictive value of the RSBI. But then Tanios et al. Went and tried to see if they could validate this. And they looked at about 900 adult ICU patients. It was mixed medical, surgical trauma, and neuro ICUs. They looked at all mechanically ventilated patients deemed ready for weaning, right? So the patients that met those other criteria: hemodynamic stability, oxygenating appropriately, ventilating appropriately, mental status improving, et cetera, et cetera. And the primary outcome was extubation success versus failure at 48 hours. So did they need to be re-intubated by the 48-hour mark? And they used the RSBI cutoff of less than 105. And the results here were that those who had an RSBI less than 105, still it was associated with a higher probability of extubation success, but it was fairly modest in terms of the results compared to the original 1991 trial. There are still many patients with an RSBI of less than 105 that failed extubation, and some patients with an RSBI of greater than 105 that had successful extubations. So all this to say, that this is one marker amongst many markers you should be thinking about when you're thinking about liberating a patient from mechanical ventilation. As we said, a good place to start, but not the end-all be-all. Do note that this was an observational trial. It was not randomized. They looked only at an RSBI less than 105, not like multiple different RSBIs. And there's some things you couldn't really account for: airway protection, secretion burden, all that kind of stuff, which obviously can affect extubation failures. So bottom line here, RSBI's maybe, a screening tool or just one piece of data, but its predictive accuracy is not absolute, and you should use your clinical judgment and some of these other kind of clinical assessment strategies in addition to the RSBI to help guide you. So with that being said, key considerations, signs of failure would be severe tachypnea, hypoxemia, tachycardia, hypertension or hypotension, agitation, diaphoresis, right? Anything that looks like there's increased work of breathing. Trial duration that we said is 30 to 120 minutes, variability there. Failure is usually declared earlier if there's intolerance. And a big thing here, and we probably should have said this earlier, is there's incredibly robust evidence that daily spontaneous breathing trials and sedation interruptions reduce ventilator days and improve mortality. So all patients, we cannot stress it enough, all patients that qualify should have daily SBT, spontaneous breathing trials, and SAT, sedation vacations. Every single patient that improves mortality and reduces ventilator days. Absolutely it does. This should happen for all patients. All right, to end here, we'll have some practice questions, but we just put a table in here, and every one of these study guides will be on our Patreon page, which is in the video episode description. And we upload all of our study guides, practice questions, ad-free videos, med ed posts, discussions, all that good stuff. So definitely check that out. We'd love for you to join or hop on board. But yeah, the study guide will be on there if you're interested in accessing the study guide, because this table here is kind of a comparison of spontaneous breathing trial methods, including the T-piece trial, pressure support trial, and CPAP trial. And just going with setup, right? For a T-piece trial, the patient's literally disconnected from the ventilator and hooked up to humidified oxygen. For the pressure support trial, the patient remains on an inspiratory pressure and a PEEP. And for a CPAP trial, the patient just remains on PEEP. So from a support standpoint, a T-piece trial, there's no support. There's no PEEP, no inspiratory pressure. For a pressure support trial, there's inspiratory support and PEEP. And then for a CPAP trial, there's just PEEP. There's no inspiratory support. So the physiology here for T-piece trial is, post-extubation conditions. People will say a T-piece trial is closest. We actually disagree with this because it doesn't account for the resistance of the endotracheal tube. For a pressure support trial, it accounts for tube resistance, so it's arguably the most realistic. And then for a CPAP trial, it just has PEEP. It's maybe like in the middle there somewhere. Advantages for T-piece trial, it's simple, no ventilators needed, but the patient was already on a ventilator, so is that a real advantage? Probably not. Pressure support trial, it's most commonly used, it's most comfortable for patients, it's easy monitoring, and there's the most evidence behind it. And then for a CPAP trial, you at least maintain alveolar recruitment and prevent atelectasis because they're on PEEP, although you don't prevent any inspiratory pressure to get over that endotracheal tube resistance. Disadvantages for T-piece trial: increased work of breathing, overestimates failure, not supported by the evidence, requires disconnection from the ventilator. Disadvantages to a pressure support trial is, it may underestimate extubation difficulty because you do get a little inspiratory pressure support, although that theoretically, if it's low enough, should just be enough to get over the resistance of the endotracheal tube. And then CPAP trials, disadvantages are they're less well validated. People just haven't looked at them as much. Common use, we would say T-piece trials, much less commonly used today. Pressure support trials, widely used. CPAP trials, not commonly used. And then evidence, there's most evidence supporting pressure support trials, much less evidence supporting CPAP or T-piece trials. All right, let's get into some practice questions. If you have not participated in practice questions in one of our episodes before, the structures will read the question, we'll read the answer options, and then we actually just go right into the answer. So if you need more time to think about it, just pause the episode because we're going to jump right into the answer. So question 1, beginner, there will be 3 questions. Which of the following is the primary purpose of spontaneous breathing trial? A, to reduce sedation requirements. B, to evaluate readiness for extubation. C, to measure lung compliance, or D, to prevent ventilator-associated pneumonia? Pause here if you need to. The answer is B, to evaluate readiness for extubation, right? Every patient should be having a spontaneous breathing trial every day to determine if they might be ready for extubation. All right, question number 2, intermediate. A patient is on a pressure support of 5 centimeters of water, a PEEP of 5, an FiO2 of 40% during their spontaneous breathing trial. After 1 minute, their respiratory rate is 30 and their tidal volume is 300. What is their RSBI and does it suggest success or failure? So we'll do the math with you here. So RSBI, rapid shallow breathing index, equals respiratory rate divided by tidal volume in liters. This patient's respiratory rate was 30 and their tidal volume was 300 milliliters, which is going to be 0.3 liters. 30 divided by 0.3 hopefully is 120 maybe? Uh-oh. Did we do our math wrong? Good thing we have a calculator right next to us on our phones. 30 divided by 0.3 is 100. I actually think we might have done our math wrong for the answer. So it should be 100, which is B. Less than 105 is most likely success, but it's kind of right on the border. But did we put, yeah, we did. We put C, but that's not true. We just did our math wrong. Good thing we got to explore that together. So the correct answer is B, 100, which is borderline. It still meets, right? Less than 105 is that magic number that they used in these RSBI studies. But as we talked about many times, this is just a single data point. It shouldn't be totally dependent on. And then last question, question 3, advanced in randomized controlled trials, which approach was shown to shorten time to extubation? A, intermittent mandatory ventilation weaning. B, pressure support ventilation with gradual reduction. C, daily SBTs with prompt extubation if tolerated. D, routine use of CPAP trials for 24 hours. Correct answer is B, daily SBTs with prompt extubation. This absolutely is the thing that you should all be focusing on in your ICUs. Give patients, gosh, we are striking out here. We circled the wrong answer on the video. Give patients daily SBTs, right? SBT, SAT for every patient, every single day that meets criteria, that improves outcomes. Absolutely, absolutely. All right, that's all we have for you today. Thanks for sticking around. Hope it was helpful. Check out our Patreon page, YouTube platform, podcast platform, all things emergency and critical care medicine. And either way, we appreciate y'all. Stay well and keep learning. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.